Ladies and gentlemen, dear friends and colleagues, welcome to the Thorax Center where we will do the wrap-up of the EPCR 2020 meeting. My name is Nicolas from Mieghem and I'm standing here with my good friend and colleague Joost Daemen, and together we will walk through the highlights of the EPCR meeting. This EPCR meeting, as you all know, was different from the usual EuroPCR because we have this COVID-19 pandemic. It was 2 weeks later than our TO meeting. The TO meeting was a very dynamic live broadcast. EPCR was pre-recorded, but still interesting in a lot of aspects. So here we go. I think, Joost, maybe the first topic that we want to address, PCI and DAPT.
Yeah, so as usual at PCR, a lot of focus on PCI and DAPT. And at first, I want to highlight the presentations that were given based on the new high bleeding risk ARC definitions. So there were three presentations that I think are worth mentioning. The first one was the trade-off model, which was presented by Philippe Urban. He presented a trade-off model for high bleeding risk based on over 6,000 patients with high bleeding risk criteria from 6 randomized controlled trials. And these patients mainly comprised obviously of patients of elderly age, so aged above 75, use of Coumadins, renal failure, or those with anemia. And in the model, the investigators looked at the predictors for either BARC3 or 5 bleeding, or ischemic endpoints defined in this case as a Meyer stent thrombosis. And what they found is that in patients with high bleeding risk, there was an equal risk of bleeding versus the risk of MI and stent thrombosis, while in patients without high bleeding risk criteria, there was a lower risk of bleeding, but also a significantly lower risk of MI and stent thrombosis. So that already points in the direction of the fact that these criteria for either bleeding or ischemic endpoints largely overlap. Mieghem then presented the new HBR ARC definitions validated in the burn PCI cohort. So as you know, in burn they have a similar PCI registry as we have in Rotterdam, in which they follow all patients that undergo PCI in routine practice for a longer period in time to look at differences between stents, but now also for bleeding risk criteria. So this registry used here included over 16,000 patients, so a large single center real world registry. And what they found was quite interesting is that the ARC high bleeding risk criteria identified 1 out of 3 patients that finally experienced BARC3 to 5 bleeding. Remember, these bleeding definitions is quite stringent, 2 is not included. So the number of patients is relatively small, but still the definitions only identified 1 out of 3. But what I found was that 65% of the patients experiencing BARC3 to 5 bleeding occurred in those who fulfilled only minor criteria from the HBR definition. So this already implements the fact, or means that it's not just the major known criteria like multiple criteria, higher age, Coumadin use, anemia that put patients at risk, but maybe also the less stringent ones like COPD or liver failure that at the end will matter, which would mean that the cohort which meets the criteria increases substantially. And that was actually finally also confirmed by Hirofumi Hiyoki, who presented some data from the Ultimaster registry, the Model U CES registry, in which 50% of the patients, around 1,500 patients, fulfilled the HBR-I criteria for high bleeding risk. And what they found is that these patients had a risk of NACE that was 71% higher as compared to those who did not fulfill these criteria. But perhaps, and then in line with the previous comments, interestingly, this increased risk was driven by an increased risk for each of the individual components of NACE. So bleeding, but also all of the ischemic endpoints. So at the end, it was interesting. It makes you think a little bit more on the individual risk per patient. But on the other side, I'm still puzzled how this will be feasible to be implemented in routine practice.
But also, as we are now moving to different antithrombotic regimes, right? We're no longer, I think we are deviating from DAPT also in patients at lower bleeding risk because there does not seem to be a penalty in dropping aspirin. So I'm wondering down the stretch whether we will need these high bleeding risk scoring.
Well, it's a two-edged sword. It's bleeding, but also ischemic endpoints. But because what Philippe Urban presented was quite interesting, the mortality rate after ischemic endpoints is twice as high as compared to the mortality rate after bleeding. So I think the patient-tailored approach it still needs some fine-tuning, but that will take time.
Yeah. Okay, so in the same bleeding context, there was also a trial that was focusing on left atrial appendage occlusion and comparing LAA occlusion versus a NOAC. Basically, what this particular trial that was presented at EPCR was doing was it was comparing the Amulet Observational Registry and then trying to match over 1,000 patients from that registry with more than 18,000 patients from a Danish registry. So basically what they found was that the annular stroke rate was the same for the NOAC patients as for the patients who underwent LAA occlusion, but there were less bleedings. The major bleedings were 40% lower when patients were treated with an LAA occluder, and in this particular case the Amulet, and that also resulted in a 50% mortality reduction. Well, I think we have to be very cautious with the statement that LAA occlusion in those patients is the way to go. I think this is a propensity matched analysis. And basically it is somewhat in contrast with a randomized trial that was presented at ESC last year and that we also discussed in the ESC wrap-up last year, which was the Prague 17 randomized trial from the Czech Republic. That trial included more than 400 patients randomized to NOAC, predominantly apixaban, or LAA occlusion with Amulet or Watchman, and then there was no difference. No difference in bleedings, no difference in stroke or mortality. So I think, in conclusion, let's be very cautious with these registry data. There was also a recent cautious publication in the New England Journal stating that randomized trials remain the way to go if we want to shape up our practice.
Yeah, I agree.
So more on PCI. One of the more interesting studies presented on in the online PCR was a subgroup analysis of COMPLETE, presented again by Tesh Seth. So as you all know, the COMPLETE was this big blockbuster, 4,000 patients with STEMI and multivessel disease, randomized to either complete revasc or culprit only, showing a 26% reduction in hard clinical endpoints like death and MI at 5 years with the complete revasc arm. Interestingly, complete revasc was performed based on visual and geographic estimation of lesion severity, of lesions that were, according to the individual operator, more severe, worse than 70% visual estimated diameter stenosis. So, and in this subgroup, the investigators assessed the impact of the severity of these non-culprit stenosis when they were assessed post hoc by QCA. And what I found was interesting, so they made a threshold of 60%. So remember, visual estimation was 70, for QCA it was 60. And they first of all found that 1 out of 3 lesions that were classified as severe by the individual operators proved to be, let's say, less severe with QCA, meaning a diameter stenosis less than 60%. So they looked and they disentangled the treatment effect and looked for the fact to see whether the complete revasc was perhaps more beneficial in those with the more severe stenosis. Well, that appeared partly true. So from a hard clinical endpoint perspective, that was a clear difference. If you stented the more severe lesions, that indeed resulted in a 39% reduction, but that did not account for the less severe lesions. So if the QCA diameter stenosis was less than 60, there was no difference, no more any difference in the hard clinical endpoints. Interestingly, and that is something I'm still a bit puzzled about, if you take the secondary endpoint, which included revasc, there was a difference in both arms. So if you stand everything you see, both the very severe lesions as well as the perhaps less severe lesions of a diameter stenosis of perhaps 50 or 60%, they also did better in the long run. So that makes you wonder what the additional value could be of more intense lesion characterization with either imaging or physiology, or perhaps in the future some less invasive hemodynamic indices like angio-based FFR. If we are moving in a direction in which we also want to show a benefit in terms of hard clinical endpoints. So interesting.
Well, when I think about COMPLETE, I think it's a very good, a very powerful trial, and it partially resolved a question. What do you need to do? How do you need to approach patients with multivessel disease who present with the STEMI? Well, I think the answer from complete is, well, you really have to aim for a complete revascularization. But still, you know, I want to emphasize again that the timing of the revascularization was not stipulated. I mean, you were not allowed to do ad hoc complete revascularization. And that brings us again to the BioVast trial that is currently ongoing and randomizing patients between with multivessel coronary artery disease and ACS to ad hoc complete or staged complete revascularization. So more to come on that particular topic.
Yes.
Bifurcations.
Yeah, so more on standing, very short. I think nice to mention that was the large ultimate master registry, which included over 4,000 bifurcation lesions. And Bernard Chevalier again presented some data on how we treat bifurcations in real-world practice. So in this large cohort, over 4,000 patients, and what they found, few messages I think are nice to mention. Event rates were higher in true bifurcations. You say, okay, well, that is something that you expected. There was no difference in 1 versus 2 stent strategies, although there was a higher risk of stent thrombosis with 2 stents, also not really expected. But this was not stratified, so this did not account for the type of bifurcation. Final kissing balloon inflation did not do impact on any of the outcomes, so that to me was interesting. However, POT, so final proximal optimization therapy, clearly impacted the outcome in any of the patients with the bifurcation lesions. So I think that is was a very strong message that stood out to me again to be highlighted, because this is something that we encounter a lot in our routine practice.
Any data on invasive imaging?
No, zero. At least I haven't seen it. That is one. Issue number 2 is that event rates for bifurcations lesions were relatively low. Target vessel failure was around 6% at 1 year, which is relatively low. So that again, fits a little bit with the registry character of this trial.
Well, I think what we have seen in the last decade maybe in terms of bifurcation treatment is that we are looking as a community for a one size fits all, right? We want to, is it provisional, is it 2 stents? But I think in practice, when you would use imaging guidance, then maybe you do not need to use kissing balloon in all patients. So I can imagine that, for instance, in this registry, the kissing balloon was not mandatory or not necessary for good results, because maybe they were doing more imaging also, right? So I think
could be. I don't think so in this study, but the good thing is it was large, and that's why I think the messages have some value. I mean, it's over 4,000 again bifurcation patients.
But that brings us to the imaging, invasive imaging.
Yeah. So 2 very interesting parts on imaging, which I want to highlight, both on OCT. One was the Light Lab initiative. So the Light Lab initiative was a initiative, which was set up in the US among 12 leading interventional cardiology sites together with Abbott, in which the aim was to assess the use of OCT in routine practice. And the idea was to look at how the use of OCT changed practice in these, let's say, mature large volume sites when you look at the new proposed MLD max algorithm. So what is that? Because they obviously had to put some thresholds in where do you look at when you see how does it impact your practice. So they proposed this new algorithm that had a pre-PCI and a post-PCI part. So the pre-PCI part was the MLD part, standing for morphology, length and diameter. And the second part was the post-PCI part, max, standing for the 3 key components that finally define outcome, being either submedial dissections, apposition, and stent expansion. So interestingly, what I found is that in over 600 patients who participated in this registry, OCT changed angio-based decision-making in almost 88%. So that is a lot. Why? Also interesting because the vast majority of the changes, or perhaps the most particular one, was in patients with calcified lesions. So OCT changed the lesion preparation strategy in over half of the patients. And that to me, I think, is something that is very interesting and also fits with the complete hypothesis on why imaging might help to improve outcome, because you tackle calcium in a different way, you're better able to adjudicate the effect of lesion preparation, and you will be better able to optimize your stent results thereafter.
And especially if you also take into account the expanding toolbox for calcified lesions, right?
Exactly.
You have shockwave, you have orbital, rotational atherectomy, you have all the balloons that we have at our disposal. Yeah. So I think imaging might help in the decision-making process, how to approach it.
Definitely. What was also interesting, two parts here, which I think I want to briefly highlight, is that we always say that if you use imaging, you use larger stents. Well, that appeared not to be true. In this case, 1 out of 8 more or less patients, operators, let's say, pick larger stents based on the OCT, but also in 20%, 15 to 20%, they picked smaller stents based on the imaging, as they would have done based on angio alone. Second, I'm not sure the registry fully managed to assess the impact of the use of OCT in routine practice. What Abbott did is they put product specialists and each of the individual sites. So individuals with a lot of expertise on imaging who really scrutinized the individual components of the MLD max criteria. So this to me tells you what it could do, but what it will do in sites that are perhaps not high volume OCT users obviously still needs to be determined.
And isn't it amazing that this study is in 12 high-volume centers in the United States, and still product specialists were required? Yeah, so what about the local expertise then?
Yeah, so I would not put any conclusions to that, because that was simply part of the registry. I mean, the volume of parameters that they needed to collect was so extensive, apparently, that at least according to the sponsor, was the reason they put all the specialists there, not only to help with the OCT, but also to collect the data. Okay. More to come. Even more interesting on OCT was again a study by Chengang Chu from China, who presented a artificial intelligence-based lesion characterization algorithm. So what they did is they used over 500 pullbacks, OCT pullbacks from 3 OCT studies, and looked at lesion characterization. So they had 3 independent core labs independently assessing plaque type from OCT pullbacks, so either lipidic, calcified or fibrous. And what they found is that these core labs actually managed to achieve a very high agreement of approximately 80 to 85% for all these plaque components. But then more interestingly, they also assessed the potential of the new OCT Angio Plus software, also from China, in which an AI-based algorithm managed to identify the individual components with the core lab defined plaque characteristics as gold standard with an accuracy of 90%. So this to me could, if this would be implemented in the software, that would be great. I mean, specifically for operators that were not that well trained or are not that well trained, this will help, and this will definitely help the implementation of OCT and plaque characterization.
No question. I think if you can make OCT something that becomes straightforward without interpretation. So if you would have some kind of artificial intelligence that helps you tell you what can be seen on the OCT image, that would be a major breakthrough, I think.
Definitely.